Recently, a patient came in complaining of chronic debilitating pain in their left shoulder. There were a few things that were notable about this case. First, there was no mechanism of injury. There was no specific incident, no moment in time, nothing that this person could point to that would have led to an injury. The pain just seemed to come on out of nowhere. Second, the symptoms had remained exactly the same in the 10 to 12 months since the problem began. There was no change at all in the amount of pain that they were experiencing or their level of disability. It just stayed constant, and that's a little weird. And finally, despite having seen multiple practitioners of various sorts about this shoulder problem, the patient had no idea what was causing their pain. They were completely in the dark, and they'd never even been given a diagnosis. And so in this video, I want to show you how I quickly go through an examination with a patient like this to determine what's causing their problem and whether or not they're a good candidate for rehabilitation. A patient's examination officially begins the instant they walk into the clinic. I'm watching how they move, I'm checking the alignment of their body, and I'm seeing how they carry themselves. And then when we get back into the treatment room, I do a complete structural analysis where a ton of valuable information can be gained really quickly once you know what to look for. So starting at the top and working our way down, what we see in Chris's case is that his head is rotated very slightly to the left. Now it's only about 5 or 10 degrees, but it's definitely there, and you can tell because when looking at him straight from the front, his right ear is much more visible than his left ear. Moving down to his shoulders, we can see that he has a significant left shoulder hike. So the left shoulder is much higher than the right, and it creates this appearance of kind of a downward slope towards his right shoulder. Moving down from there, we're looking at the backs of both of his hands. So we're staring directly at the knuckles, which is an indication that both shoulders are resting in deep internal rotation, which destabilizes the shoulder joint. Moving down from there, it's hard to tell what's going on at the hips because of the clothing, but when you get down to his feet, you can definitely see that his right foot is much more turned outward or externally rotated than his left foot, which could be indicative of some kind of imbalance at the pelvis. Next, I had Chris perform a few basic ranges of motion so that I could see how that problematic shoulder moves and compare it to the unaffected side. So first up is shoulder flexion, and we're starting on the unaffected side. Watch how that right arm just fires up there, and the humerus or the upper arm bone actually finishes back behind his head. So great range of motion on the right-hand side. Now let's see how he does on the left. Starts off pretty good. As he gets to the top, though, you can see that it stops short about 15 degrees short of the opposite side. And the other thing that you see here is he actually dips his head forward as he gets into that difficult end range. And that is something that we're going to see him repeat as we go through some other ranges. Now moving on to shoulder abduction. Again, right side fires up smooth and easy, full 180 degrees, completely effortless. Notice how his head stays stationary on the right-hand side. Moving over to the left side, he starts off pretty good, and then you can see it slows down right about 90 degrees. And as he gets above 90, there's like a hitch where the pace of the movement changes significantly. And then when he gets to about 160 degrees, he starts dipping his head, and his head moves significantly more forward from 160 to about 170 degrees. And the reason that Chris is doing that is he's getting into a more advantageous position to use accessory muscles, specifically his upper trapezius, to do the heavy lifting when he gets into an area where his shoulder is not functioning the way that it's supposed to. And then there was one other bit of solid gold information that Chris let me in on, which was when he gets his arm into a specific position where the elbow's bent to about 90 degrees and his hand is out in front of him, and he goes into abduction, his shoulder completely stops at about 85 degrees and he can't lift it any higher. Like, he described it as being physically blocked from moving any higher, with a sharp pain accompanying that blockage. So this was really interesting and definitely something that I wanted to look into deeper. So with that bit of extra information, the next thing that I did was to passively move his affected arm through the restricted range of motion to determine if there actually was any type of physical blockage. And it also gave me the opportunity to compare passive motion to his active motion to get some idea of what structures may be involved in his problem. And that one simple test gave me a bunch of really important information. First, it showed me that there was no physical obstruction inside of his shoulder joint. I was able to passively move his arm through that range of motion without any problem whatsoever. But there were obvious signs of instability and muscular weakness, and so I immediately followed that test up with orthopedic testing to check the integrity of his rotator cuff. So you can see here, starting with the empty can test on his unaffected side, he holds that arm out in front of him, turns the hand downward, and I push down on it, and I can't move it at all. Then we move over to that left-hand side and watch the expression on his face when I even reach up to touch it. He's uncomfortable before I even get my hand there, and just the lightest pressure with my fingers, and he is unable to hold his arm in that position. Strong indication of a tear in the supraspinatus, and I follow that up with strength testing of external rotation, and again, +5 normal on the right-hand side, super weak on the left side. So from here I move on to palpation, and I palpate all along the supraspinatus, and when I get out to the insertion, you can see him wincing with the direct pressure. And so the working hypothesis based on the information that we've gathered so far would be a grade 1 strain of the left supraspinatus with compensatory hyperactivity of the accessory muscles in the area, most notably the left upper trapezius. In plain English, that means that he's got a partially torn rotator cuff, and because that muscle is not functioning the way that it's supposed to, he's been using his neck muscles to lift his arm for the last 10 to 12 months. As far as therapy goes, I had 3 goals working with Chris. The first was to ramp up activation in his left supraspinatus. The second was to increase the stability of his left shoulder joint. And finally, I wanted to deactivate the accessory muscles at the base of his neck here. To accomplish all of that, I had him perform an isometric external rotation exercise where I positioned him right up next to a wall, about 12 inches away, with his feet running parallel to the wall, had him bend his elbow to 90 degrees and tuck that elbow right into the side of his body, and then take the backs of his fingertips and press him up against the wall like this. But before having him exert any force whatsoever, I had him take that left shoulder and draw it back and down, almost like he was shoving his left shoulder blade into his left rear pocket. In addition to that, I had him draw his chin inward and press the crown of his head up to the ceiling. This elongated those muscles at the base of his neck and made it really hard for them to contract, while at the same time increasing the stability of his left shoulder joint, making it easier for him to exert force and putting his rotator cuff muscles, the ones that are responsible for that external rotation, into a mechanically advantageous position. And then from there, maintaining that upright posture with his shoulder back and down, I had him push in this direction, like turning his fingertips outward while pressing his left elbow into the side of his body for 15 seconds continuously, pushing only as hard as he could go without experiencing any pain. At the end of 15 seconds, I had him rest and then perform a second round. What you're looking at here is Chris's range of motion in bilateral shoulder flexion immediately following 2 rounds of activation exercises. And what you'll notice right off the bat is how symmetrical the movement is between the 2 sides. There's increased range of motion on the left-hand side, and the upper arm on that affected side now comes back behind his head just like it did on the unaffected side. His face is much more relaxed because he's not experiencing pain as he goes through this movement. And what he said to me there is that he noticed the areas around his left arm and shoulder blade where the muscles used to be tight were now loose, and so he was able to move much, much easier. The other thing that you'll see is that he's no longer dipping his head forward. His head stays nice and tall because he doesn't need to use those accessory muscles in his neck to get those final 10 or 15 degrees of movement. And then finally, as he brings his arms down, you'll notice that the left shoulder is much more even in terms of height with the right shoulder, indicating that the muscles at the base of the neck on the left-hand side are relaxing as the muscles in his left rotator cuff turn on and begin doing their job. And so based on Chris's strong positive response to this one super simple and easily repeatable intervention, I'd say the prognosis for his left shoulder is really, really good. Guys, that's going to do it for this week. If you found this video interesting and you'd like to see more content like this with lessons from the clinic, let me know about it in the comments section down below. Beyond that, I just want to thank you so much for watching. Make sure to hit that thumbs up button and the subscribe button before you head out of here, and I'll see you next time.